director. I have all of the hospitals. I have, long story short, I have responsibility for both acute.
It doesn't work.
Oh,
Sorry.
no!
I'm so
Well, it was nice meeting you. We'll see you again next time. I ultimately have responsibility for both acute rehab centers, both at the one here in Memorial and at Grossmont. I have all of the therapies in all 4 of the acute care hospitals. I have all the therapies in the skilled nursing facilities through the Sharp Healthcare System, and about 19 outpatient clinics also at the same time. So if you don't see me here a lot, it's only because I'm in transit most of the time. But do they have handouts?
No, but I can get the.
That's okay. That's all right. Yeah, sit back and relax and enjoy this as much as you can, because I'll try to be as visual as I possibly can without the PowerPoints being up here on time. Long story short is I'm here to talk to you a little about the financial stuff that's not only going on in the system, but it's going on at Sharp Memorial Hospital at the same time. And a lot of people refer to me as the gloom and doom presenter, but I like to think of more of the fact about what's going on, what's happening in the real world, and for everybody to just sort of be on the same page with an understanding where healthcare in general is going. First and foremost, profitability is really based upon 3 separate things. It's based upon volumes, it's based upon payer mix, and it's based upon cost containment. And if you look at the slide up here that ends up showing you what I'm trying to say is, what happens is that there's a slide up here that actually breaks down all the different reimbursements by revenue per case and by expense per case. And long story short is the slide has Medicare and Medicare products, Medi-Cal, capitation, and traditional insurance. Long story short is we are not making money on any reimbursement case except for traditional insurances. I can still remember where our dilemma falls in this whole thing is that we cannot believe nor can we sustain the fact that we think traditional insurances are going to be able to cover the costs for all those other payers that we're not being able to get more reimbursement for instead of what our costs are. So that is our challenge. Our challenge is to be able to look at our costs, to look at what's costing us to do stuff, because reimbursements are just dropping. That's across the entire country. Insurances are just not willing to be able to pay what they used to pay in the past, especially the government entities, the Medicares and the Medi-Cals at the exact same time. So on the slides that you see here up in front of you, 14% of all of our reimbursement for all of the cases that we do come from traditional insurances. So 14%, that margin has to cover all of the loss per case that we have across all the other payers at the exact same time. And I think you guys can probably understand that is not sustainable. That is not something that's going to continue. I went to a leadership development about probably 8 or 9 years ago, and the traditional insurances in the Sharp Healthcare System was 22%. It's currently 14% at Sharp Memorial Hospital. So that number keeps on doing this, our expenses keep on going up, our reimbursement goes down. So long story short, that is our challenge, to be able to, the only thing we really have control on really is to be able to maintain costs and control costs. And I'll talk to you a little bit about how we do have direct responsibility and ability to be able to affect that stuff. Real quickly, I want to talk to you guys about the capitation word. I don't know if you guys have ever heard of capitation or not. It's a huge piece of what we get reimbursed here in the Sharp Healthcare System through Sharp Steele and through Sharp Community Medical Group. Capitation, this is the 30,000-foot level I'll give it to you. Capitation is predicated upon something that's called a PMPM. It's per member per month. And it is a fixed amount of money that the hospital and the system gets every single month, per member per month. And the way it's calculated is, it's really not that complicated. They take the total number of enrollees that are within that insurance plan, and they multiply it by some contracted, established rate. So long story short is, say that we were covering for SCMG 500,000 lives. This is totally made up, okay? But actually, it's pretty close to 500,000 lives. But just follow me on this. This is an example. And say we get $6 for every single one of the enrollees. We get $3 million from SCMG in the month to take care for all of their patients who are on a capitated plan. Now, what happens is that if we exceed that $3 million in our expenses, we lose money. If we keep it below $3 million, we make money. So it's really not hard to figure out. The problem is that all of the risk associated with capitation falls on us. There is no risk to the payer at all. It's totally and completely up to us to be able to manage those costs and manage that operation. Now, the other piece on the Medi-Cal side is Medi-Cal and the managed care and the Medi-Cal products continue to grow enormously in the state of California. And you guys know that Medi-Cal is California's version of the federal government's Medicaid. We just are special in California. We just set up our own plan at the exact same time. 1 in 3 Californians are on some type of Medi-Cal or Medi-Cal managed plan. 1 in 3. And you guys know the state doesn't pay us really well to be able to take care of people. So that's additional sort of influence on us at the same time that we have to be aware of. So I wanted to talk to you real quickly about things that we can actually do as departments to have an impact upon the stuff that's going on around us when it feels like it's totally out of control. We have the ability to be able to truly control maximizing our revenue when it's there, as well as controlling our costs at the same time. But let's start with first maximizing the revenue. First and foremost, probably one of the most important things that we can do is ensure that our charges are put in correctly. I can't underestimate, to you guys especially, the nurses in the room, your documentation drives the coding for reimbursement. If you don't put that something was done and something occurred, then when the coders go in to be able to look at stuff, we are not going to get paid for that stuff if the documentation isn't there to be able to support what's going on, what's happening. Certainly another piece associated with that is the charge entry with regards to supplies and procedures that are performed. We have to make sure that all of that stuff in, because that all leads basically to the bottom line with enhancing our revenue. So we just need to minimize the amount of loss. So we need to really work on that as much as we possibly can to make sure that those things are as clean as they possibly can be. And just as a point of interest, there is actually a system charge reconciliation system group going on right now to address those things that we just talked about right now. How to enhance that, how to make that as firm and as whole as we possibly can. Now, let's talk about the expense side, because you guys go, well, what the heck can we do on the expense side? Actually, there's a lot that we can do on the expense side, and stuff that we basically have to be aware of. The first thing I want to say is, you need to understand that if we increase the amount of patients that we're seeing, that does not necessarily mean, oh, you're close.
Which number? What slide?
I'm on like 16.
Okay. Sorry.
No, you're good. Keep going. Okay, here, before you go. As you can see, here's the 14% of the traditional insurance. You can see that we're covering per case. Our revenue exceeds our costs, but you can see in every other area, our reimbursement per payer does not cover the expense associated with any given cost. So thank goodness this is as good as it is, but this is not going to be sustainable as time goes on, because the insurances are keep on negotiating more and more and more to drop these rates as much as possible. So that is really a snapshot associated with what reimbursement is. Okay, we talked about the charge accuracy and the reconciliation. A combination to code reconciliation, make sure documentation supports those things. We talked about supply and procedure charges, as well as how important it is for you guys to be able to document everything you're doing and how you're doing it. With regards to the ordering of supplies and standardization, I'm a firm believer of this, that not only from the hospital side, but certainly from the system side, that we are going to have to be able to systemize a lot of the stuff that we do and to standardize things so that we actually envelop everybody in the best practices that people have and share across the system at the same time. I think that's the only way that we probably will be as successful as we possibly can be in the future, by sharing those best practices from one another and implementing them. Now, we talked about increasing admissions and volume. Again, increasing admissions does not mean more money that falls to the bottom line. It all depends upon the payer. So the net revenue and the net profit will not increase just because we see more patients. So what we do, associated with that is we need to be able to implement and look at ways of being able to control our costs at the same time. One of the major ways of being able to do that is throughput. It's really a safe mechanism, and it's really an efficiency system as far as throughput is concerned, is that certainly you probably have heard this, that we need to try to get patients out of the hospital as quickly as possible because it'll end up saving money. But throughput is bigger than that. It's got to be a safe process so that we're as efficient, as effective as we possibly can be through the entire patient's hospital stay. That includes therapies. It includes labs being done in a timely way. It includes pharmacy doing what it needs to do. It's making sure they get their radiology stuff also done at the same time. It has to be a systemic, and it has to be really a combined effort by everybody to be able to get there. Now, outcomes are obviously very, very important because outcomes are looked by insurance companies about whether they want to contract with us and at what rates they want to contract with us. So certainly the better the outcome results, the better chances we are of getting good rates as far as our reimbursement is concerned. But the other thing is not only the impact on contracting, but public reporting. You guys probably know this right now, is that the public can go into the internet right now and find out what different hospitals' results are and what their outcomes are, at one time or another. So they are using that data to decide whether they want to come to Sharp or whether they want to go somewhere else. So the public reported data is absolutely critical at this particular moment in time. Now, we talked about also from the standpoint about public reporting. There are penalties associated with what we report, to the feds, to CMS at the same time. Last year, we paid back Medicare, we'll just call them the feds for general, over $1 million because of how the hospital performed on CAUTI. We were way above what the benchmark was. We paid a penalty of over $1 million back. So that is something that we can control. I don't know, $1 million can go a long way for a lot of things that are needed and absolutely necessary at the same time. Now, patient satisfaction is something I think we would all agree that we have some impact upon, from a small piece to a large piece. Patient satisfaction is a part of what's called the HCAHPS, which is what information and quality data we send in to Medicare at the same time. Patient satisfaction of part of the HCAHPS pays 30% of what we end up being basically reimbursed or associated with the different incentives or penalties that we end up paying. So with regards to patient satisfaction, we talked about the public perceptions. Public perceptions are the way we deal with people, we manage people. I think it's also important to recognize that there are abilities for the public to be able to go in and see what's going on, what's happening with regards to our outcomes. And patient relations department, it's something as small as lost belongings that can have a huge impact upon what our patient satisfaction scores are at the same time. So living the Sharp experience, giving everything you can to the patients, don't think that just goes unnoticed. It actually is reflected in other data that we end up sending into the federal government. Now, length of stay. This is a huge, huge piece associated with it. It's certainly got to be a management and an operational focus, certainly in our future at the same time. And I always preface when I have this conversation is, we have a limited control of that. It's really the docs that play a major part associated with it when they end up wanting to discharge somebody or keep somebody. But those lengths of stay are very much determined by the physician, but we can also have an impact upon that at the exact same time. It's been estimated that dropping the overall hospital length of stay by a 0.1 length of stay, that's 2.4 hours a day. If we were able to drop the discharge by 2.4 hours a day across all of our patients, it's estimated that the hospital would save $6 million. A 0.1, 2.4 hours getting somebody out earlier would save $6 million a year. Seems like sort of an easy way to be able to go. I think you guys know that it isn't that easy because you don't necessarily have control of it, but it is something to keep in the back of your minds of something that is certainly an opportunity for all of us to be able to look at. And certainly the need to avoid delays, whether it's therapy treatments, procedures, meds, equipment, consults, and education. The quicker, the more timely, the more efficient we are in getting these things done, the greater opportunity we have in being able to drop that length of stay. So it's truly a throughput issue for sure. And I think we have to start to think about discharge at the time of admission. I know in rehab we do that also at the same time. But discharge, when the patient comes into the unit, has got to be something that we need to look at in order to promote the patient and move the patient through the system as quickly as possible. Now, real quickly with regards to preventive and expensive medical conditions, whether we're talking about falls, whether we're talking about skin breakdown, whether we're talking about CARDI, whether we're talking about C. diff, whether we're talking about CLABSI, or any of those hospital-acquired incidences, those all occur without any additional reimbursement. If something happens to a patient, we can't bill because a problem or something occurred. That is totally and completely on us. So I think you guys can understand this is a huge opportunity for us to be able to do so. And certainly with regards to coordination and collaboration, this is amongst and between all the different departments. We cannot work in our own individual silos. We have to be able to work with one another to maximize that throughput and getting the patient out of here as quickly as possible. So it's really sort of all of our responsibilities and all the department's responsibilities to be able to do that. And certainly from a regulatory compliance, if we do not meet the benchmarks that are established by CMS and / Medicare, there are fines that are associated with it. We talked about the CARDI just a moment ago, but another one that we also can end up getting a fine for or being punished for are readmissions, the amount of readmissions that go on. So I think you guys can see a lot of this stuff we do sort of have control of. It is not out of our ability to have an impact upon it. I think the other things that come to mind that we can control, and I know that we're looking at certainly within the system, is staffing mix. Do we have the right mix of patients that are doing the stuff that needs to get on? The other one is flexing the volume. If things are lower, people don't end up coming in to work, which I know you guys probably deal with a lot. My wife's an ICU nurse, and she got called off this morning because things are slow at UCSD. The other one are employee injuries. I don't really think that we necessarily think of that as being something we have control of, but you being as safe as you possibly can be is absolutely critical. I believe that currently on a typical sprain and strain, just a sprain and strain, not with all of the other indicators for employee injuries, it's about $18,000 per, on average, a sprain and strain. So if there are 300 plus employee injuries at Sharp Memorial Hospital and the aggregate is $25,000, that's a boatload of money that we're paying that could go to something else. Plus, at the same time, we want to keep you out of harm's way at the exact same time. Oop, there was one more. Now, there you go. 19. Now, this is an old slide. We couldn't quite find something that was a little more current, but I'm going to bring up the current. These are the high cost of medical errors, which we talked about. So I'm going to just give you the current data as I did a sort of a search on this. There was a study done at Johns Hopkins. They have estimated that there are nearly 250,000 medical error deaths every single year throughout the United States. And there's another study that said as many as 440,000 deaths because of medical injuries and medical errors that are caused also at the same time. Medical errors are the third leading cause of death in the United States, only exceeded by heart disease and by cancer. It's the third leading piece. And then the Healthcare Finance Journal put out an article about a year ago that basically outlined the fact that they feel that medical errors are costing up to $1 trillion a year in follow-up and all the activity associated with it. So medical errors are certainly an area that we can certainly focus in on. It's a huge area of opportunity. And it's an area of opportunity, one that certainly we can control. We can help prevent. I'm not saying all of them are totally preventable, that's for sure. But it is an area that we need to focus in on really to maintain certainly the health of our patients and at the same time help maintain some financial solvency at the exact same time. So I'm done. Not that I can answer them, but I'll be more than happy to. Sure.
Trying to get patients out in Jasper. Have they ever done any kind of a study as to whether keeping departments open on the weekends, like having physical therapy, full staff on weekends, or MRI on weekends, so that people don't wait till Monday to have a test done?
Well, and I'll answer my question because this is a great, and actually, I'm not so sure I'm glad you answered the question, but I'm glad you answered the question. To me, I don't know if increasing the expense by putting more people on the weekend is the way to look at it. I look at it in a completely different way. And I met with a number of physicians about 4 years ago, and they said, Dave, you know, we order this stat order, and then we can't get your person up there because we book every single day to be able to do stuff. I said, you know what, guys? If you know the patient's coming in on Wednesday, and you're pretty sure they're going to be going home on Saturday, why don't you just freaking drive the order for us on Thursday, and we'll have everything waiting for you on the chart by the time the patient's ready to go home. So I look at it a little bit different than and try to increase the expense.
You know they're coming in. I mean, that's not the case on our floor.
Right on your floor. But I think we try to take care of the stat stuff as much as possible, but we do have a limitation for sure because when we have our people, they are booked all the way through the entire day when something stat comes in. So to be maybe a little more proactive with the physicians or up forward with the physicians as quickly as possible. Yeah, we do. Obviously, we have nurses that are on call. And I'm not going to be... Expense is a huge item, and I'm dealing with my other facilities at some of the other hospitals where they've already got slashed and burned on their fiscal year 2020 budget, so they don't have those extra FTEs to be able to do it. So I think the approach is that we're looking at trying to do things smarter and wiser without actually having to throw more staff at it if there's a way of being able to do it. But it's a good question.
Any more questions?
Great. Thank you, guys.
Thank you.